computer. Okay. Hi, everyone. I'm Ann Hartley, and I'm here with Dr. Chen, a pulmonary specialist here at Rush. Hi, Dr. Chen.
Hello, my name is Elaine Chen, and I work as a pulmonologist and also as one of your clinician educators.
So we're going to talk about asthma. Dr. Chen, what is asthma and what are the key features?
Well, asthma is a super common condition that we see that's really, I would say clinically, the most important thing that I think about is that there's obstruction that comes and goes. It's not always present, but it is the hallmark of the disease. Maybe I'll share some slides to kind of give you a real bird's eye overview of what we've got.
So this is one of the obstructive diseases like COPD, but the obstruction is intermittent. All right.
So this is, I took this from our literature and it's super old, but the concepts haven't really changed. So the hallmark of asthma, I would say, is what we see right here, airway hyperresponsiveness. And then the question is, what causes this airway hyperresponsiveness? I can't remember, airway smooth muscle contractility, airway remodeling, and airway interdependence, but really it's led to by inflammation and some sort of triggers. There are lots of different kind of models and, shall we say, methods of describing asthma, which we will say the triad. So reversible airflow obstruction. And obstruction, as you remember from your physiology, is where the air has a hard time getting out, the expiratory flow decreases. It's reversible, and the key point there is that it is present sometimes, and when a patient is not in exacerbation, it may be completely gone. Airway inflammation, so that's the kind of things you have learned about from your immunology courses with mast cells, eosinophils, which are triggered by IL-5, and then IgE. And then airway hyperresponsiveness, which, as a very simple way to say it, I would say that airway obstruction develops as a reaction to a trigger more often than it does. So it develops in an asthmatic more often or more quickly than it would in a non-asthmatic.
So that's like the definition of airway response, hyperresponsiveness. So someone without asthma wouldn't have a reaction, but someone with asthma, their airways are hyperresponsive to that trigger.
Exactly. And by hyperresponsive, this is another way to say it, is bronchospasm. So the small airways are spastic. They're reacting when they're not supposed to be. And then these are all, this is just another different schematic of a potential triad. So this is a nice open airway. And then this happens. So airway edema, which is a result of the inflammation, mucus production, also a result of the inflammation, and bronchospasm is the smooth muscle contraction leading to, so you'll see this, it's constricting, the airway is getting smaller, and then it is filled with mucus plugs in the middle. And lastly, this goes back to the first blue slide. We talked about the bronchoconstriction, which is the same thing as bronchospasm. This is brief, and it is reversible with the application of a bronchodilator. However, as asthma progresses, you may see that people do have chronic obstruction where it's not fully reversible anymore due to the chronic airway inflammation that leads to airway remodeling. So when I say some people may have reversible obstruction, but at some point the asthma may progress and the muscles may thicken and become so changed that there does become fixed airway obstruction.
And Dr. Chen, how often would you say that an asthmatics, or how many of your patients are in? Is that a pretty small proportion of patients that have that chronic remodeling? Because generally we teach that it's fully reversible, but I guess there is that small proportion of patients where they reach a point where they don't have complete reversibility. Is that true?
Yeah, I would say There's also a component of overlap between COPD and asthma. And then we talk about reversibility, and there is complete reversibility and partial reversibility as opposed to something that is fixed. So it is a really wide spectrum. And as a pulmonologist who takes care of longstanding older asthma patients, I may see more fixed airway obstruction than in the primary care world. At least I hope so. I hope that most people don't progress to the point where they have fixed airway obstruction.
Okay, great. For our students, I would say that generally we're going to think of COPD as being the irreversible obstruction, and most of asthma, most patients having a reversible process. So it's an intermittent disease by definition with triggers. Okay, great. And can you talk a little bit about airway resistance and how airway resistance is different than compliance and the role that that plays in the disease?
So airway resistance and airway compliance are two of the concepts that I really struggle with. And so I hope I can distill it to something brief and simple enough for you to understand. We don't really think of compliance too much when we're thinking about asthma. However, it's important to think about just in juxtaposing the two concepts. I would conceptualize it airway compliant or lung compliance. It's the whole lung. It's the stretchiness versus stiffness of the lung. And so I think of it like balloons. You've all blown up balloons before, and you've got those those long skinny balloons that the balloon artists use to make like those animals. Those are real tight and stiff, and they're really hard to blow into. So those have really low compliance, as opposed to like a giant balloon that you just blow into and the air just fills it up. That has really high compliance because it's very, very stretchy. I think that's all I'm going to say about compliance right now, just the concept stretchy versus stiff. Resistance, on the other hand, talks about how the air flows in and out of the alveoli through the airways. So it's physics, and I'm not good at it, but we all took some to get here. So the smaller airways do have more resistance when they get narrower. So that we saw that schematic earlier of the, and should I share that again? I think
I like the constricted airway with mucus plugs.
Exactly. So this one is constricted, it is smaller, and there is mucus plug. So you can see that the air flowing in and out of it has a much harder time than in this large open one. So this one has higher resistance.
So resistance is really the term that applies most aptly to asthma, since we're talking about it as a disease of the airways, whereas compliance is more like the whole lung.
Exactly. And let's see. And then they also teach that the resistance is inverse to the radius of the airway. So a smaller airway, much higher resistance. It's actually inverse to the fourth power, I believe.
Yes, yeah. And Dr. Shannon's pretty good about talking about that.
Okay, good.
And so, Dr. Chen, when you see asthma, patients with asthma, how do they present? What are their signs and symptoms?
So patients can present on a huge spectrum. It depends on whether you're talking about a patient who presents in an acute exacerbation of asthma. Why don't I talk about that first? So, they've been exposed to some sort of trigger, and this process has happened, and there is active bronchospasm going on. So they'll probably be pretty tachypnic and pretty short of breath. And what they say is, I can't get enough air. The irony is that they're getting enough air in, they're just having a harder time getting the air out, but they feel like they can't get enough air. You may see as it gets worse, they may be showing signs of respiratory distress using accessory muscles of respiration, abdominal breathing. When it gets really bad, we call it tripoding, where they're leaning forward like this to try to get the air in and out. You may hear some upper airway wheezing. So you may hear them wheezing from across the room, which tends to be an upper airway process. And when you place your stethoscope on their lungs, we'll hear what we call as our traditional wheezing. Generally, so earlier on when it's less severe, we hear expiratory and expiratory high-pitched sounds. and a prolonged expiratory phase. So the expiration takes a lot longer than inspiration. Normal inspiratory expiratory ratio is about 1 to 2. And when it gets very prolonged, 1 to 3, 1 to 4, 1 to 5, is what you might hear with your stethoscope on their lungs. If you hear that literally from their mouth, it may be coming from the upper airway, but if it's very severe deep down, you may hear that outside. As the wheezing progresses and gets worse, we sometimes call it musical or polyphonic, where you may hear several different pitches of wheezing at the same time. And traditional wheezing is diffuse throughout the whole lung. So you should hear it in the upper lungs as well as the lower lungs, left and right, anterior and posterior, if it is asthmatic wheezing. One of the concepts that I was reading about is that it is diffuse, but not necessarily homogeneous. So a little bit here, a little bit there, a little bit here, a little bit there, but it is everywhere. If it's only in one area, you want to think about a more localized obstruction rather than asthma.
Okay, great. What about cough?
Cough is a super common presentation in asthma, and it's completely nonspecific also. Some people may not even wheeze. Good point, Dr. Hartley. They may just have cough variant asthma, which would probably still present with obstruction on a PFT, but without the audible wheezing.
Okay. And what about your very sick patients in the ICU? What unique findings do they have?
Well, as if the airflow obstruction gets really, really bad, they may actually be unable to exhale the air. And so this is really severe. If you see this, it's something you really want to be worried about. They may develop a hypercapnia where they're retaining their CO2. So, normal CO2 is about PCO2 is 40. In acute asthmatics, you usually expect that to decrease because they're so tachypnic. And then as they're so obstructed and they're starting to retain a PCO2, something like 45 or higher becomes very worrisome that there's impending severe respiratory failure. It's a mild respiratory acidosis, but due to something that may require more advanced airways. And then pulsus paradoxus is something that we read about in your textbook, and it's something I don't see often clinically, but it makes sense in that the lungs are so full of air during the inspiration. They're so hyperinflated that you decrease your venous return. So your blood return getting back to your heart decreases during inspiration.
So pulsus paradoxus can happen in severe asthma as well as hypercapnia. So I would say with mild to moderate asthma exacerbations, you'd expect the patient, because of the tachypnia, to actually have a low PCO2 and have a respiratory alkalosis. And if an asthmatic has an elevated PCO2 and has a respiratory acidosis, that is very ominous that they could be developing impending respiratory failure, because despite the tachypnia, their obstruction is so severe, they're not breathing off all that CO2. Is that about right?
Yeah, I would agree with that. And
Okay.
then I just wanted to point out that when I see my patients in return visits in the office, they often look normal. They may have no wheezing, no cough, they may feel great, and they may be on a whole spectrum of pills and inhalers, or they may be on very little. And oftentimes they look and sound the same with no wheezing, no tachypnia, no signs at all. And on PFTs, there may be, like I said earlier, mild obstruction or not at all.
So how do you diagnose it then, especially if you have a patient that you've never seen before that is reporting that they were told they had asthma as a kid, perhaps, but they look totally fine when they walk into your office? How are you going to diagnose them?
Oh, good question. So, it's asthma primarily, I would say, is a clinical diagnosis. If someone tells me this story that is very consistent with asthma, were exposed to a trigger, they had trouble breathing, they left the trigger and their breathing improved, or they took some allergy medications and their breathing improved, or we gave them or they borrowed their sister's inhaler and immediately they felt better. They were wheezing, they felt chest tightness. So the story is very consistent and responds to treatment. So what kinds of treatment? First line treatment for an acute bronchospasm is always a short acting bronchodilator, or albuterol is the first line. And if somebody improves with that and doesn't need more, that's all they need. That's a clinical diagnosis of asthma. I don't need further testing. I don't need further treatments, just an inhaler as needed. Now, if they are getting worse, then I might start, step up, step down therapy, a whole different lecture. And then if it's so severe that I'm giving them steroids, and again, that's not unusual. I don't need any further testing yet. I have patients that come in. I really can't breathe. It's getting tight. I'm using my albuterol 6 times a day and it's not reversing it. We'll treat with corticosteroids. A short course of oral prednisone is the standard, and they respond to it. And our asthma patients will respond very, very quickly. You give them a dose of prednisone, 40 milligrams, which is the standard treatment for an adult, and they will feel better by the next day. Maybe not in minutes to hours, because it does take a while for the drug to kick in, but by the next day, they will feel way better and they won't even call me back.
Great. Okay. And then what if you do still have some doubt with your clinical diagnosis? Is there testing you can do to help confirm the diagnosis of asthma?
Absolutely. It can confirm or it can rule out asthma. So first of all, we'd always want to do PFTs, spirometry in particular. Let me see. I think I have a schematic of a variety of different kinds of PFTs. So just real basic, our normal, the upper is the expiratory limb and the lower is the inspiratory limb. And just a few things that I think about when I look at these. The inspiratory limb is usually about half as tall in general as the expiratory limb. And here they're talking a normal 20-year-old versus a normal 50-year-old. And the normal expiratory limb is a nice smooth line, almost straight line. And you'll see here, this is just the normal put for comparison. So I would always get PFTs to try to rule out any other condition. Really, is there actually the presence of COPD and fixed obstruction already, or concurrently? They often overlap, and so you'd call this an overlap syndrome and think about the different pathophysiologies and are they both present. I would expect normal spirometry in earlier asthma. Is there a restrictive condition instead or in addition where the shape of the flow volume loop looks the same as normal? It is just basically shrunken. And is there the presence of some obstruction? This doesn't diagnose it per se, because like I said, many of our asthma patients will have normal PFTs. It's not uncommon that somebody says to me, Dr. Chen, this patient, I don't think they have asthma because they have normal PFTs. Well, I'll say, yeah, well, they're not in exacerbation right now. Their PFTs should be normal. But if we do PFTs while they are in an exacerbation, then we expect it to be abnormal.
Yeah,
It's not something.
I feel like this really illustrates the reversible nature of the disease, right? And the intermittent nature of the disease. Because you could have someone who has asthma, they definitely have it, but their spirometry is completely normal. Whereas if you have a patient with COPD, they may be a little better, a little worse, depending on what kind of treatment they're on, but they'll always have some fixed obstruction. Is that right? So they'll always have that scalloped expiratory phase.
Absolutely. If the scalloped shape is there, they're calling this mild, moderate, and severe with a prolonged expiratory phase. The prolonged expiratory phase, there's no time here. So it just means that the flow is slower towards the end of expiration. That if it's fixed, that is more consistent with COPD or, as I said earlier, very, very advanced asthma with severe airway remodeling.
Great. Okay, wonderful. So I think we've hit all of the things that we wanted to talk about. Is there anything we've missed?
I did want to talk about this was my picture on resistance. I apologize, I didn't have it up earlier. I think I had them in the wrong order. But right here, the forced breathing, and this says emphysema, but the concept is the same with asthma and emphysema because it is bronchospasm and obstruction. There's dynamic narrowing of the airways.
And what does that mean, dynamic? Does that just mean that it's intermittent?
Yeah, it comes and goes.
Okay.
Yep. And then So the methacholine challenge is a further test that you can do to confirm or exclude asthma. So this is, we'll order this test if we have a doubt of the diagnosis. I think this is asthma, but it's not really classic. I don't hear wheezing. Maybe it's for a chronic cough. Maybe they're complaining of exercise induced type of symptoms, but no specific, allergic triggers, because there is just exercise induced asthma. So what we do in a method, and the other thing is to rule out asthma. Sometimes I'll have patients come to me saying, doctor, I am pretty sure that I have asthma based on this clinical diagnosis. And I'm like, well, it doesn't really quite sound like that to me. Why don't we get this test and we can tell you for sure whether you have it or you don't. And some people might be super grateful. I don't actually have asthma because this is a negative test. Okay, so normal. So first we get spirometry, and we just look at what it looks like. So it should be one of these pictures, normal. And then we're trying to drive obstruction. That's what we're trying to find. And by definition, with the methacholine challenge, we're looking for a decrease in the absolute, the percentage of FEV1 by 20%. So let's say your FEV1 at baseline is 100%, and we give you this medication and we trigger it and we want to drop it to 80%.
And so an asthmatic would react, it would develop obstruction with the methacholine, but someone who doesn't have asthma would not develop an obstruction. Is that right?
Well, the drug is so strong that in everybody there will be a reaction at some point. That's what the drug does. It induces obstruction. It induces this response in the lungs, but the hyper responsiveness is where the obstruction develops earlier than you would expect in a normal.
At a very low dose.
Exactly, a lower dose. So what we do is we get one. We get the first spirometry, just normal. And so that's 0 because there's been no change yet. And then we give this low dose, 0.25 milligrams per milliliter, 0.5 milligrams per liter, and then 1 milligram per milliliter, and all the way up until you induce this change. Now, we don't keep going and going and going if the obstruction develops. So you've got your severe asthmatic, you're just at the third one, and their FEV1 now has dropped by 20%. They went from 100 to 80. They went from 2.5 liters to 2 liters in their FEV1. And so at that point, I would say this person has responded too soon. They have hyperresponsive airways. Their FEV1 dropped by 20%. This is a diagnosis of asthma. Your mild patient may need a couple more doses before they drop by 20%. And so you're normal. You'll give all the way, 8, 10, 12. We don't go all the way this far in our testing. We probably go to about here. And if you get to 8 or 16 and you still haven't developed bronchoconstriction, we say that you do not have hyperresponsiveness.
Okay, and just for the students, you don't need to know these numbers on this graph, and you don't have to know these curves. You just need to understand that patients with bronchial hyperresponsiveness, asthmatics, will develop obstruction and their FEV1 will drop at a low concentration versus a normal person. And I think the number we discussed yesterday, Dr. Chen, was 12%. If we have a 12% or greater change, then that is indicative of obstruction. Is that right?
So the 12% change actually is in the opposite direction.
Oh,
so
right.
For the diagnosis,
right.
Yeah, the methacholine, your FEV1 has to drop by 20%.
Right. Okay.
Of the baseline. The 12% is, okay, so here we are, we've given this patient this much methacholine, and now they've developed obstruction. And for them or for anybody else, I'll go back to this slide. After we've caused obstruction, we give a bronchodilator and the FEV1 improves. Now, in our patient to whom we just gave methacholine, we expect that it'll improve from whatever it dropped to back to its full baseline. For a patient who may be in exacerbation at the time that we did their spirometry. So let's say they look like this, and then we give them a bronchodilator, and the reversibility is that their FEV1 improves by 12% at
Right.
that time. So
Got
the
it.
FEV1 improves by 12%, that's reversibility.
Got it. Perfect. Okay, wonderful. Thank you very much. Anything else we need to cover?
Well, we could go on and on and on.
Excellent. Okay. Thank you very much, Dr. Jen. I really appreciate your time.
Thank you very much, Dr. Hartley.